I think the issue, without going on too much of a tangent, is that, one problem is that we don't really know what chronic hypertension is. So chronic hypertension, is it, when you look at chronic hypertension, you look at the EMR, you say my patient's hypertensive, has been a chronic hypertensive, then you look at the blood pressures. Maybe there's been blood pressures at 5 previous clinic visits, and all of them are actually fallaciously elevated blood pressures. So you don't really know what your patient's sweet spot is, because, usually we get a blood pressure either because patient has gone to a doctor before they've come to the emergency room or the ICU or the operating room, or because a patient has gotten a blood pressure when they first arrive in the hospital, right? And then you try and say, okay, this one's chronic hypertensive and has a blood pressure of 150/90 on his or her last office visit. Those are never appropriate or clear blood pressures. We always feel that there's an element of white coat hypertension there, or anxiety-driven hypertension. So if I had to truly establish chronic hypertension, I would have ambulatory blood pressure monitoring on patients and then try and establish that sweet spot. The unfortunate part is that we don't have that clearly available right now. The future is wireless wearable devices going home with patients, and patients being able to track their own blood pressures and then bring that device with them when they come to the acute care environment, and we being able to see the trends of blood pressures over time in a resting state, and being able to target our hemodynamic therapy. To answer the specific question, for now, yes, I do modify my vasopressor and fluid therapy to that higher blood pressure, but within reason. I absolutely have to do it within reason. I'm not going to go after someone's blood pressure of 200/120. I won't do that, but I'll still modify my therapy accordingly. Only baseline status we have is the pre-operative holding room area blood pressures, or the pre-anesthesia clinic blood pressures in an elective case. Sometimes we don't have any blood pressures. So that, which really is frustrating, because then we have to go to the usual map of 65 for everyone, which really isn't the best approach, because if you've been a chronic hypertensive, say for 10 years, and especially if you haven't done well in taking care of your hypertension, then your autoregulatory curve is shifted off to the right. I don't know how much to the right it's shifted. It's impossible to determine that. And it's just pure guesswork at some point, saying, okay, let's keep a map of 65 and hope for the best. But sometimes these patients wake up with a subclinical stroke or an actual stroke, which is really, really unfortunate.